Hello, my name is Jack Thomas, and in this presentation, I'm going to talk through my dissertation, which explores how a psychoeducational intervention can influence awareness of help-seeking barriers among rural men. I have chosen this topic due to being a rural man myself, and growing up in a small community, the issue of men's mental health has always been, in my opinion, seen but not heard. The rural men in my community have often shouldered the burden of providing and being independent in silence. And in my experience, I have never witnessed conversations between men in the community, despite how important it really is. Men's mental health is widely recognised as a major public health concern. In the UK, men account for around 75% of suicide deaths, despite experiencing similar levels of psychological distress as women. And what makes this particularly concerning is that men are significantly less likely to seek help. When we narrow that down further to rural communities, the issue becomes even more complex. So, in rural areas, men often face structural challenges, things like geographic isolation, reduced access to services, longer travel times, and fewer specialist resources. But beyond that, there are also strong cultural influences. Traditional masculine norms, such as being self-reliant, emotionally controlled, and handling things yourself, tend to be more deeply embedded in rural settings. So, all these circumstances create a situation where men may be struggling but feel unable or unwilling to reach out. That's why rural men's mental health is often described as a silent crisis, because the difficulties are there, but they're not always visible or openly discussed. Although awareness of mental health has improved more broadly, there's still a clear gap when it comes to engaging men. Particularly in rural communities, a lot of existing interventions are quite generalized. They focus on raising awareness, but don't always consider the specific cultural and environmental context that shapes behavior. For example, simply telling someone that help is available isn't always enough if they feel that seeking help conflicts with their identity or how they think they should behave. What this study aimed to do was explore whether a psychoeducational intervention could help bridge that gap. More specifically, it looked at whether the intervention could increase awareness of the barriers that rural men face, improve understanding of mental health and distress, and increase confidence in recognizing and responding to others. Therefore, rather than measuring behavior directly, the focus here was on awareness and perception, because these are often the first steps toward behavior change. So, the central research question guiding this study was, how does a psychoeducational intervention influence awareness of help-seeking barriers among rural men? And to explore this in depth, a qualitative approach was used, allowing participants to reflect on their experiences and interpretations of the intervention. To understand how this intervention might work, the study draws on three key ideas. The first is mental health literacy. This is about how well people understand mental health, including recognizing symptoms, knowing when to seek help, and understanding what support is available. Research suggests that low mental health literacy can delay help seeking, particularly in men, because symptoms may not be recognized or taken seriously. The second is masculinity and help seeking. There's a large body of research showing that traditional masculine norms like emotional control, toughness, and independence can act as barriers. For many men, asking for help can feel like a loss of control or even a threat to their identity. And the third is social cognitive theory, which suggests that people learn behaviours by observing others. So when men can see other men, particularly those they can relate to, openly discussing mental health, it can challenge those norms and make help seeking feel more acceptable. That's why the intervention included personal testimonies to provide relatable examples that normalise those behaviours. The intervention itself was a 1-hour psychoeducational session delivered to university students. It included a mix of statistical information about mental health to explain the severity of the issue, personal stories from rural men as a means of connection and understanding so that other men can relate and realise it is not taboo, education around warning signs for support systems to learn and recognise psychological distress, and a framework called the Roots model. The Roots model was used to help structure understanding of barriers and has been categorised into 5 barriers. Starting with rural, this refers to geographic challenges, things like distance from services, isolation, and limited accessibility. The geographical isolation imposed on rural communities plays a strong factor in accessing services, as it is more likely to find better trained mental health professionals in urban areas, while rural areas may offer services in lieu of carers, GPs, and other medical staff that may not specialise in mental health support. Then occupational, which includes economic and work-related pressures. For example, long working hours, financial instability, and physically demanding jobs can make mental health feel like less of a priority, especially when their jobs also force them to work alone for long periods of time. Outlook refers to cultural beliefs, particularly around masculinity. This includes ideas like needing to be strong, not showing vulnerability, and dealing with problems independently. Thoughts focuses on internal psychological barriers, things like stigma, shame, and low mental health literacy. These are due to lack of education on mental health and the feeling that expressing oneself shows weakness. And finally, social factors, which include lack of privacy, fear of judgment, and concerns about confidentiality in small communities. What's important here is that these barriers don't exist in isolation. They interact with each other. For example, someone might already feel reluctant to seek help due to stigma, but that's reinforced by a lack of anonymity, which is then reinforced again by limited access to services. Therefore, the Roots model was designed to show that help-seeking behaviour is shaped by a complex system rather than simply individual choice. It is important to understand these factors in order to address each issue at its core. In terms of methodology, a qualitative approach was used. 7 participants took part in focus groups following the intervention. Focus groups were chosen because they allow participants to share experiences, reflect collectively, and build on each other's ideas, which is particularly useful when exploring perceptions. The data was then analysed using reflexive thematic analysis following Braun and Clark's framework. In terms of procedure, participants were recruited through the university's sonar system, attended the intervention, and then took part in focus groups a week later. Lastly, all the recorded transcripts procured from the focus groups were analysed using reflexive thematic analysis. Because of the sensitive nature of the topic, particularly discussions around suicide, ethical considerations were prioritised throughout. Participants were reminded that they could leave at any time and were given access to support resources. So, three main themes were identified in the analysis of the transcripts from the focus groups. They shed light on the most important takeaways produced in the study and act as a foundation for identifying the effectiveness of the study. The first theme was rural context as a barrier. Participants highlighted isolation, lack of anonymity, and stigma as a barrier that stopped men from seeking help. When at risk of gossip due to tight community circles, the idea of approaching for help becomes unattractive due to judgment. For example, one participant stated, "Everyone knows everyone. It's probably easier not to speak." This suggests that the visibility within rural communities can actually discourage help seeking. The second theme was increasing awareness of the issue. Participants reported that the intervention helped them better understand the issue, particularly through statistics and personal stories. It helped them learn about warning signs of distress and how to aid such behaviour. Using statistics demonstrates the extent of this issue and lends motivation to support systems to prevent their loved ones from being a part of such statistics. The third theme was from awareness to action. Participants felt more confident supporting others, especially when they understood how important it is to be part of a support system, as well as how it can prevent negative feelings from the people they care about. However, this also raised concerns about whether the impact would last over time. So overall, the intervention had a clear immediate effect, but its long-term impact remains uncertain. Overall, these findings align quite well with existing research. The barriers identified, particularly around masculinity and stigma, are widely documented in existing literature, and the increase in awareness supports research on mental health literacy, which suggests that education can improve recognition of distress and supports behaviours. What's particularly interesting is the role of personal testimonies, because they seem to make the issue feel more real and relatable, also aligning with research showing that narrative approaches can reduce stigma and increase relatability. However, a key takeaway is that awareness alone may not lead to long-term behaviour change. So while interventions like this are effective in raising awareness, they may need to be repeated or reinforced over time. There were several limitations to consider. The sample size in the intervention was small and consisted of university students rather than rural men themselves due to accessibility and because this intervention was designed to raise awareness of rural men's mental health among non-clinical populations. and the intervention was delivered only once, being a one-off intervention, may also explain the concerns around sustainability of the impact of the intervention. So, while the findings are useful and have provided interesting feedback for future research, these findings are currently not necessarily generalizable. Therefore, there are some important implications of note after conducting this intervention. Psychoeducational interventions like this are relatively low cost, accessible, and easy to deliver. They could be integrated into community settings such as schools, colleges, or community groups, particularly at early and recurring stages to have a greater impact on the community. They could play a role in starting this important conversation, help gradually shift attitudes about this sensitive topic to a more positive light, and help reduce stigma in community circles. It is important to consider that future research conducted on this topic should address the limitations of the study. Future interventions should be tested with a participant pool consisting of mainly rural men and their support systems to have a bigger impact. Additionally, there should be follow-up studies to gain feedback about the usefulness and the true effects of this intervention. Lastly, the intervention should be held repetitively over a duration of time in order to maintain the sustainability of its impact. So, to conclude, rural men face a complex combination of structural and cultural barriers, which have been factors affecting their mental health to such proportions that it is considered a stigma to talk about it, much less seek help for issues like it. However, through psychoeducational interventions, starting the conversation on how to help men by recognizing distress in actions and behaviours, understanding how to help when seeing warning signs, and supporting men of the community, there can be an impactful and positive change in rural communities. This study shows that psychoeducational interventions can increase awareness and improve confidence in help-seeking behaviour. However, for a long-term impact, these approaches likely need to be sustained over time, and future research has the opportunity to build on this study and learn how to navigate studies that can negate the limitations affected here. Ultimately, improving awareness is an important step toward reducing stigma and addressing mental health inequalities in rural communities. Thank you for listening.